That I think points to this kind of binary tendency that either a problem is a problem of biology, or we want to say that if the problem is not a clear biological problem or a problem biological abnormality, then nothing much is to be gained by understanding the biological dimension of it. Mental health problems, mental disorders exist precisely in this middle ground, where they are not primarily problems of biology gone wrong. Mental health problems are problems of behavior gone wrong, and psychological experiences gone wrong, but they nonetheless have a biological dimension, and they because they have a biological dimension, we can study that, we can intervene on that, often in kind of remarkably effective ways at times.
Welcome back. Today we're exploring the question, what is the role of philosophy and philosophical thinking in psychiatry and mental health? And it's not actually me conducting today's conversation, but my co-host, Dr. Anya Borisova. For those of you newer to the podcast, she's a clinical and academic registrar at the South London and Maudsley Trust, and today she's in conversation with Dr. Awais Aftab. Dr. Aftab is a psychiatrist working in Ohio in the US, and is also the clinical assistant professor of psychiatry at the Case Western Reserve University. Dr. Aftab is interested in philosophy and the history of psychiatry and writes about these topics on his Substack, Psychiatry at the Margins. He's also the author of the recently published Conversations in Critical Psychiatry. Today's conversation focuses on the philosophy of psychiatry, what assumptions and frameworks shape the field, and how this impacts things like diagnosis or decisions about treatment, or understanding mental disorders. They discuss what defines a mental disorder, how biological, psychological, and social factors interact with mental health, the evolution of psychiatric diagnoses, and how these have shifted over time, the benefits and limitations of psychiatric medications, their potential harms, and some of the public relations challenges that psychiatry has faced and continues to face in the modern day. As ever, it's really helpful if you can give us a rating or a comment or a review. We really enjoy hearing from you. And you can also give us feedback directly at our email at thinkingmindpodcast@gmail.com. This is The Thinking Mind, a podcast all about psychiatry, psychology, self-development, and related topics. We hope you enjoy, and as always, thank you for listening.
Hello, everyone. I'm very excited to be joined by Dr. Awais Aftab for this week's episode of the Thinking Mind podcast. Dr. Aftab, welcome and thank you for joining us.
And thank you for having me.
You are a psychiatrist and you write blogs. You do a lot of thinking about what the practice of psychiatry should be like and how it can be improved. What got you thinking about this? What made this important for you?
I had been interested in philosophy for a long time. Even before I started med school, I was interested in philosophy, and in fact, I was considering the possibility of going into philosophy as an academic profession. But I was in Pakistan at the time, and philosophy as a kind of profession was just not really a viable option. So I ended up in medical school, and in medical school, I realized pretty quickly that psychiatry was a subject that interested me. It felt a great fit for my temperament and also for my interests. And so I started pursuing psychiatry, and to my delight, I discovered that there's this huge overlap between philosophy as a discipline and the subject matter of psychiatry. And there's this burgeoning field of philosophy of psychiatry, which is inhabited by medical professionals, by psychologists, by philosophers. So I started reading up on that and started getting familiar with the literature, and I really got interested and curious about fundamental issues in psychiatry, various kinds of concepts that drive our clinical work and our scientific work, and I started realizing how fundamental they are to clinical practice and scientific practice. So my profession as a psychiatrist, my career as a psychiatrist, I have used the opportunity to explore these basic questions with the help of the philosophical literature.
What, as a quite a novice to philosophy, and I imagine a lot of our listeners are as well. Could you give us more of an idea of what kind of questions those are, even what philosophy means, particularly when applied to psychiatry?
Yes. So in the range of questions that are subject to philosophical analysis or philosophical inquiry is pretty broad. But a helpful way to think about is what are some of the assumptions and ideas that are guiding clinical work, and what are some of the basic concepts that we rely on in the field. So a basic concept that is ubiquitous is the idea of mental disorder or mental illness. So we can ask about when we characterize a behavioral state as being disordered, or when we characterize a behavioral state as being an illness or a medical problem in a certain sense. What kind of judgments are we making? To what extent are these judgments grounded in facts about biology or facts about physiology? And to what extent are these judgments grounded in various values that guide human decision making? To what extent are these values social cultural in nature? To what extent are these driven by perceptions of distress and judgments of harm? And what is the end product of this confluence of judgments? When we classify conditions within the realm of mental disorders and within the realm of mental health problems, when we, let's say, draw a line between depression as a syndrome and anxiety as a syndrome, what is the nature of that classification? What exactly are we carving? Are we the kind of categories that we have separated out? What is their metaphysical status? Do these categories possess an essence, a unique singular category that is particular to or specific to that group? Or are these just, for example, practical groupings that we're using for our practical purposes, and they don't necessarily capture the underlying structure of the problems or mechanisms of the problem? So these are metaphysical debates around what we call essentialism and pragmatism. And then when we look at the nature of psychiatric explanation and nature of psychiatric knowledge, we can use a philosophy of science perspective, and we can think about how science progresses. How is it that scientific knowledge is generated? What kind of limitations, biases it is subject to? What is the relationship between our theoretical understanding of a phenomena and the phenomena as it exists, independent of human concerns or perception? So we can apply a lot of those philosophy of science questions about realism, anti-realism, and epistemology, and the basis of scientific knowledge to psychiatry as well, and think about how is it that psychiatric knowledge is generated? What is it that we are trying to study? What kind of inferences we can make? And we can also look at the methods of knowledge production. What kind of perspectives are being excluded, for example, from the way we currently generate psychiatric knowledge, and what are the consequences of those things? And because psychiatry deals with behavioral phenomena, but also deals with brain mechanisms and processes, we inevitably come up with these philosophical issues around the mind-body relationship. So what is the relationship between mental health symptoms, behavioral disturbance experiences, with what is happening in the brain? To what extent we can reasonably think of mental disorders as being brain disorders, and what are the advantages and disadvantages of thinking of them in that kind of manner? What can conceivably be the limits of biology in explaining these problems? So that's just I'm going through a list of some of the questions that psychiatrists interested in philosophy and others working in this area tackle, but it's just a subset of things that are being discussed.
I guess to go back to one of the specific examples, so you talk about, for instance, using a philosophical viewpoint to inquire around diagnoses like depression, anxiety, and to what extent these might be separate entities, to what extent they're categories that are sort of pragmatic to use. What do you think about that question?
Yeah, so the kind of people involved in these philosophical debates, you'll hear them talk about natural kinds, social kinds, and practical kinds. Natural kinds are categorizations that reflect the structure of the natural world as it exists, independent of human interests. A good example of that is the periodic table of elements in chemistry and physics. It captures something genuine about the way elements exist and they're distributed. It corresponds to the structure of the atomic nuclei. It has tremendous explanatory and predictive power. We based on the position of the element in the periodic table, we can predict a lot of things about them, and it is the correct, objectively correct way of categorizing and classifying elements as well. If we imagine different chemists, starting from different theoretical ideas about what elements are, if they do empirical work good enough, if they're doing scientific work correctly, over time they would all converge onto the same model. So it's exists independently, captures it has powerful explanatory value and independent of human interest. Versus in think of so those are natural kinds. The complete opposite are social kinds, and these are categorizations and distinctions that are almost completely dependent on human interests. So a good example of this would be something like the political borders. They're entirely dependent on human perceptions and human negotiations. They exist in our minds, so to speak. There's nothing in the natural geographical landscape that corresponds to the border itself. And if humans were to suddenly despair, the political borders would no longer exist. And as human conflicts occur, we change these border space based on our negotiations. So that's an example of something that depends on human interests, almost completely, with no correspondence to the natural world. And in between natural and social kinds, there is this messy gray area of what we call practical kinds. And these are phenomena that are enmeshed with human interest, and that we have multiple ways of looking at this phenomena from different perspectives, different angles, depending on what it is that we want to achieve. And depending on what we want to achieve, we can make categorizations that are useful to us, but they are not the one objectively correct way of looking at it in the same way as the periodic table of elements is. So a lot of classifications in medicine, and a lot of them in psychiatry, tend to fall into this area of practical kinds. Now there are exceptions to it. So, for example, infectious diseases are a clear example of natural kinds in medicine. Whether a syndrome is caused by a spirochete infection, we can identify, we can discover that it's a well-defined entity. And things like autosomal genetic disorders can come pretty close to something like that too. But for other conditions, like depression, anxiety, psychosis, that are highly heterogeneous, and where kind of the boundaries are fuzzy, and the actual distribution of symptoms is very dimensional as well. Any boundaries and thresholds that we draw, and any distinctions that we make, they are not going to be the one objectively correct way of looking at it, but rather it's kind of question of what it is that we want to achieve. If we want to achieve, for example, a schema that corresponds to response to treatment, that is going to look very different from some classification that optimizes, let's say, genetic associations. And if you want to optimize something like neuroimaging findings, a schema based on neuroimaging finding is going to look very different from from clinical description, for example. And then that's what we see. So to speak of this in other terms, people talk of validators and convergence of validators. When we are dealing with natural kinds, the validators tend to converge. They all tend to point in the same direction. Versus when we are dealing with practical kinds, there's a misalignment between different validators, and different validators point towards somewhat different things, and how to optimize that depends on what it is that we want to accomplish. So there is, it's not, so we cannot make things up. It's not arbitrary, but the optimal solutions will depend on goals that we have set for ourselves.
Okay, so how you think about depression as a psychiatrist, or how you think about finding the boundary between depression and anxiety, will depend on whether you're, for example, thinking about what kind of treatment to prescribe versus how to explain that to the patient, or how the patient might understand it themselves.
Yeah. So the first thing to note is that even in terms of symptoms themselves, depression and anxiety share symptoms. So the boundaries between them are fuzzy for based on that reason alone. So many things like sleep disturbances, distractibility, irritability, other changes can be seen in both. And then depression and anxiety as syndromes are highly comorbid as well. People oftentimes have both of them. And in fact, when you look at the way these symptoms cluster together, due to the heterogeneity and high comorbidity, depression and anxiety do not show up as distinct syndromes in the statistical sense, in the psychometric sense, but rather they show up in enmeshed together in this larger subfactor known as the distress subfactor, which is one of the kind of dimensions in a classification known as hierarchical taxonomy of psychopathology. Which is based on statistical association. So even statistically speaking, they do not separate out as distinct syndromes. Another way to think about it is you can think of it of what happened in the United States in terms of diagnostic practices. So if you look at 1960s and 1970s, anxiety disorders were kind of very commonly were the most common kind of psychiatric diagnosis and utilized and given to patients, and common treatments at that time were benzodiazepine medication. So people were getting diagnosed with anxiety, and they were a lot of them were being prescribed benzodiazepines. And at that time, psychiatrists were also working with this general idea of neurosis, which in which anxiety symptoms featured pretty prominently. When DSM-3 was published in 1980, the people behind the DSM-3 had a somewhat kind of anti-psychodynamic bias, and as a result of that, they took the category of neurosis and they divided that up into several distinct anxiety disorders. So general anxiety disorder became its own thing, panic disorder became its own thing, obsessive compulsive disorder became its own thing, and they set the criteria relatively conservatively. So for general anxiety disorder, you had to meet a threshold of 6 months in order to be diagnosed. Now, prior to DSM-3, depression did not exist as a unified entity or a unified category in the DSM. In DSM-1 and 2, you see manic depressive insanity, depressive episodes. You had psychotic depression separately. You had a depressive neurosis separately. And you even had a depressive personality kind of separate, separate. Then involutional melancholia, which was kind of depression in old age, that was a separate category. And people sometimes spoke of this primarily as being a distinction between melancholic endogenous styles of depression and neurotic styles of depression. But depression was fragmented across the manual in DSM-1 and 2. In DSM-3, it is all brought together in a unified category of major depression. And compared to anxiety disorders, the threshold is set relatively low. You just need 2 weeks of symptom period in order to meet depression criteria. And 1980s is also when we start seeing the development of antidepressant medications. Prior to 1980, depression as a diagnosis was rare. because it was only being given to people who had severe melancholic symptoms. And anyone who had milder forms, because they tended to have comorbid anxiety too, they were diagnosed with it as an anxiety disorder. Post 1980, we see this large shift that, depression starts becoming a more common diagnosis. People who would have been diagnosed with anxiety in 1960s, 1970s are now being diagnosed depression. And the treatment of selection also changes and becomes, SSRIs are being developed and others. So antidepressants start getting utilized more. Now, the symptoms have not changed. People were still experiencing the same mix of depression and anxiety as they were always experiencing. But our understanding and conceptualization of that changed dramatically. The same person, who would be classified as, anxiety disorder in one decade is classified as depressive disorder in another decade, with the same exact mix of symptoms. And what has changed is what symptoms we are emphasizing, what thresholds we are using, and kind of how we are approaching the treatment. So that's a good example of how we're not dealing with some kind of objective essence of something that we are identifying through our diagnostic schemas, but rather different diagnostic approaches emphasize different cardinal symptoms. They emphasize different thresholds, and they emphasize the boundaries between these conditions in a different way. So you could, divide up, syndromes into smaller, categories, like as we did with anxiety disorders, or you could combine previously smaller things into one big larger category, and suddenly a lot more people would fit into that.
What do you think about that, and what do you think about the present in terms of how depression is diagnosed, how anxiety is often not thought about in people who have depression? What are your thoughts on that?
I think so. I think that the first thing we have to recognize is the fluid, fuzzy nature of these diagnostic constructs. We are working with these symptom level descriptions, and we have to recognize that these are highly heterogeneous conditions. Different people are presenting with very different combinations of symptoms, and that is what we see in depression, is that people present, with depressive states in a variety of ways. Some people have very severe psychomotor retardation, agitation. They have very severe cognitive problems. They have severe anhedonia, sometimes kind of, severe existential flavor to suicidality. Versus there are other people whose depression is very enmeshed with their life circumstances. They're experiencing a very stressful time. They're going through a divorce. They're having job problems, or they have financial stressors or unstable housing, and because of that excessive stress, they're experiencing a lot of low mood and dysphoria. And then there are other situations where someone by their temperament is predisposed to high neuroticism, and that high neuroticism makes them vulnerable to experiencing low mood and anhedonia at kind of various points in their life. And perhaps they live with a certain amount of low mood and anhedonia that fluctuates with life stressors, but remains elevated at all times. So these are very different styles of depression, everyone manifesting, but in current diagnostic schemas, they're not kind of sorted out very, very well, and we everyone is being treated in a somewhat similar kind of manner. So I think we have to recognize that our current schemas don't do justice to this heterogeneity, and also the boundaries that we have made between different conditions, disorders at the symptom level. These boundaries are not respected at the mechanistic level. The mishmash of mechanisms and processes that exists between, it does not respect DSM or ICD boundaries. We see this with genetics too. The genetic associations don't respect whether this is schizophrenia or whether this is bipolar bipolar or schizoaffective or some other kind of thing. So we have to start thinking that our boundaries, whether they might be useful in terms of description in a certain clinical context, but they're not going to be that particularly helpful when we're looking at things from a mechanistic standpoint, or when we are looking at things from a psychological process standpoint. That is why when we look at things from, for example, from a psychoanalytic or psychodynamic perspective, the usual descriptive categories are less important, and what matters more is the pattern of psychological experiences. So being mindful of that, we're dealing with a multifaceted phenomena, and the boundaries we use from one perspective are not going to hold, looking at things from another perspective. And then secondly, we have to be scientifically smarter about, even at the descriptive level, about examining these things. If the traditional DSM-ICD syndromes and boundaries are kind of semi-arbitrary in the sense that they're built on clinical impressions that people have had over years, and there's a kind of semi-consensus around them, we have to look at other approaches about how we can approach them in a sophisticated manner. And that has been happening in the psychology world with the classification system known as hierarchical taxonomy of psychopathology, where people are taking statistical data seriously, and they're asking, what happens if we look at the covariation and co-occurrence between symptoms? If how do we what kind of latent factors emerge in this classification? And the answer first is that these kind of the dimensions, we see dimensions emerge rather than categories. So the phenomena are distributed in the population in a latently continuous manner rather than there being discontinuities. One, and second, we see a hierarchy of dimensions where we have symptoms and traits as being narrower dimensions, at the bottom that cluster together to form larger dimensions such as distress subfactor, fear subfactor, that then cluster together to form things like internalizing disorders and externalizing disorders and thought disorders. And then there's this very intriguing thing at the top called the general factor of psychopathology, or the P factor, that seems to, statistically speaking, explain a shared variance among all mental health disorders, and also kind of is a reflection of the fact that all mental disorders are comorbid with each other at a certain level. So just as all aspects of intelligence are in a sense linked to each other, such that we can talk about a G factor, a general factor of intelligence, all aspects of psychopathology are related to each other through mechanisms we don't understand very well, and we see a single statistical factor emerge called the P factor, and there's a very interesting debate in the scientific literature around how to understand that, whether the P factor is just some statistical way of talking about things, or whether it represents some kind of set of processes that confers some kind of general vulnerability to mental health problems. So the thing I want to emphasize is that we have to take the the pragmatic, practical nature of our classification seriously, which means being humble about their limitations and looking at these things from a variety of different perspectives and optimizing our classifications for a variety of things. Let me give you another example. So take blood pressure. Blood pressure is it's a continuum. Everyone has a systolic blood pressure, and there's nothing magical about our current threshold for essential hypertension as a diagnosis. So saying that, a 140 millimeter of mercury at the systolic blood pressure, we're using it as a diagnostic threshold, it's kind of semi-arbitrary. There's no, you could have said 139 or 141 and it wouldn't be much different. So, and there's no natural discontinuity at 140 either. It's a smooth line. So why is it that we go with 140 millimeter of mercury as a threshold? It's because we have looked at the data and we are interested in reducing the risk of future cardiovascular negative events. So we are interested in reducing the risk of stroke. We're interested in reducing the risk of heart attacks, and we're interested in reducing mortality. And if we look at we identify a goal, we look at the data, and we say what kind of threshold would make the most sense to try to optimize mortality reduction, and that gives us the answer that if you want to achieve this, then try to keep the blood pressure lower than 140. And that also gives us the wiggle room to revise it. So for diabetics, we know that even with 140, the mortality risk can be higher. So for diabetics, we set the blood pressure threshold lower, right? So our thresholds are going to be sensitive to what it is that we want to accomplish. The problem with DSM-ICD is that they haven't had clarity on what it is that they're trying to optimize. Let's say we have the threshold for depression in DSM of 5 out of 9 symptoms for a 2-week period. What is that threshold trying to optimize? I mean, it doesn't optimize treatment response because people still respond to treatment even if they don't meet that criteria. It doesn't optimize neuroimaging findings as we know it. It doesn't optimize long course of illness. So we have a variety of things in mind, and we're going about them in a somewhat muddled manner. Versus if we had clarity on what was the practical aim, what was the clinical aim, a scientific aim, we can come up with different classification schemes that optimize those goals and make more progress with that kind of clarity.
Is this something that you apply in your clinical practice at the moment? This kind of thing, or does this kind of thinking modify how you practice?
In a certain amount of way, in a certain sense, I think one is that my conceptualization of what a person is going through, what they're experiencing, is informed by that. So I'm not just thinking in terms of, hey, I'm gonna, this person meets XYZ, DSM-ICD criteria, and then I'm just gonna blindly follow the treatment algorithm. But rather, I'm thinking in this, all right, what are the different ways in which I can conceptualize this person's problem, and what way of thinking makes the most sense, for this particular patient in this particular sense. And sometimes the diagnostic category, the DSM-ICD diagnostic category, is a very useful way of talking about it. For example, let's say ADHD or autism. Sometimes it really can be a life-changing explanation for them to think of their problem in that sense. Versus in other cases, it's whether I call this major depression with anxious distress or I call this GAD, it doesn't matter that much because the person's problem is very linked to a certain life circumstances, and it's very linked to their personality and temperament, and it's much more fruitful for me to think about this person as having, hey, this is a person who is high in neuroticism, who is experiencing this acute life stressor, and this interaction is generating a current syndrome of distress for them. So it allows me to adopt a kind of flexible conceptualization, and then second thing is that I try to communicate that to patients as well, that do not attribute more reality to these diagnostic labels than they actually possess. They are symptom level descriptions of these problems, and they have fuzzy boundaries, and they can change over time, and they don't capture some kind of essence that exists in your brain, and even that superficial level explanation can be very helpful for patients, because the average lay person, their understanding of these diagnostic categories is very reductive and biomedical. It's informed by decades of this language of chemical imbalance and brain diseases. So they tend to think that these categories actually reflect the structure of how brain functions, or how brain goes wrong, or what happens neuroscientifically. So being clear about the nature of these diagnostic thresholds and diagnostic mappings can be very helpful for patients to understand their own problems in a better way.
And it's a tricky point that you bring, because it speaks to sort of a side of the debate around diagnosis that can become quite binary, and I can hear that in the explanations that you give to your patients, it's in trying to convey to them that a diagnostic category it's not like a periodic table element that is a hard natural fact. But I think that can sometimes go into an area of the debate that says, well, then these conditions just don't exist, and actually they're not worth diagnosing at all, and they aren't biological things in any sense of the word, and they are just social constructs. How do you tread that line? How do you think about those kind of questions?
Yeah, and I think we have been seeing this kind of dynamic play out in both popular and as well as academic discussions around the nature of mental illness. And my whole the direction of my academic and clinical work has been in challenging these binaries and in showing that this dichotomous way of thinking about mental health problems, in fact, it doesn't even apply very well to medicine, let alone to psychiatry, and things are much more complicated than that, and we have to be we have to use better conceptual tools than thinking of this in this binary fashion. And again, I think the problem comes down to the kind of biomedical reductive idea that people have about medicine generally. They tend to think of all medical diagnostic categories as being like infectious diseases or being like autosomal genetic disorders, when in fact most chronic conditions in medicine are highly multifactorial and can be described and classified with some degree of kind of debate and wiggle room, things like that. So and what happens is that if that is the conceptualization we work with, that medical diagnoses have essences that are neurobiological dysfunctions, then we either fit a mental health problem into that kind of category, or we just reject that understanding and we say that, there's the biology has nothing to do with this. This is completely some kind of a psychosocial kind of issue, that medical diagnostic terminology is completely unsuitable for this. So it sets people up for this kind of flip-flopping between two extreme views, versus if we understand that many problems exist in medicine that do not have an essence in the traditional sense, and we can identify problematic behaviors, based on the negative impact it has on a person's life. If a person is persistently and severely depressed to a point where they're unable to function, they're let's say they're so their psychomotor functioning has slowed down to a point they can barely get out of bed, they can barely brush or change clothes, and their appetite has gone down and they're losing weight. That represents a significant state of impairment, and there are many different biological, physiological ways in which that state can be produced or realized, which accounts for the mechanistic heterogeneity of it. So there's not going to be, there's no singular cause or a final common pathway or or a common biological deficit in all of that. But that state is clearly a state of impairment, of harm, of suffering. And if we have, medical tools to alleviate that suffering, at least for some people, in the form of medications and neurostimulation and psychotherapies, then withholding those tools simply because that condition does not satisfy some kind of abstract idea of what a medical disorder is just the wrong thing to do, in my view. So we have to expand our understanding of what it is that we mean when we call something to be a medical condition. When we encounter states of suffering that are kind of clearly outside of the norms, outside of our expected social cultural norms and other norms of functioning, and they are amenable for to be described in medical clinical terms, and we have clinical ways of helping at least some people with that. Then in my view that becomes a bona fide medical conditions, which again emphasizes the kind of pragmatic approach that I have been advocating, that these things are pragmatic constructs. When we say that depression is a medical condition or anxiety is a medical condition, we're not making a claim that, oh, there is some hidden medical cause behind these syndromes that is causing it, and that's what we're trying to fix. But we're rather simply making a very practical claim that these are states of immense suffering that are out of the ordinary by some standard, and we have things we can do, in our medical toolkit that can help a person in that kind of state of suffering.
Do you think it's useful or necessary to identify the brain basis for those states of suffering?
I think it's useful and in some ways even necessary to try to have a scientific line of inquiry that seeks to understand what the brain mechanisms and processes involved are, because acting on those mechanisms is one of the ways in which we can better improve the lives for those individuals, and because we are our minds are embodied. We don't have free floating mental substance that exists independent. All of our behaviors are mediated by the brain. So even extreme impairing, disabling behavioral states, they are somehow the brain processes through their in their complex interaction are somehow producing them, and those states are somehow emerging in the ways that brains interact with with the environment, and then the way that brains interact with other brains in our interaction with other people. So there's a brain basis to that to be discovered and to be talked about. Now it's not going to eliminate the need for us to rely on psychological behavioral language to describe stuff that is going on, because when we use psychological cognitive language, we're approaching these phenomena at a higher level. We are talking about how we're not just talking about a brain in isolation, but we're talking about a brain in interaction with the environment. We are talking about multiple brains. So the language of neurology, for example, cannot capture those interactions, because the language of neurology is focused on what is happening inside one brain, versus the language of psychology and psychodynamics is captures those higher level dynamics, higher level interactions quite well. And many times behavioral health problems are linked with those higher order things. We are dealing with our how we are perceived by other people, and things that other people say to us, and our status within certain things. And we're talking about things in the states that we have acquired through learning and behaviors. That all of that remains essential. But for certain, for many of these conditions, learning more about how is it that the brain mediates these behavior. Why is it that some people get stuck in certain depressive states, even when they desperately want to change their own behaviors, that they are not able to? And what role, for example, does neuroplasticity play in that? Why is it that in certain cases there's a very strong family history of mental health problems, and why is it that in some people genetics seems to confer a huge degree of vulnerability? And the thing with genetics is that genetics factors cannot directly manifest in psychological terms. Any expression of genes has to go through cellular pathways and expression in brain networks, etc. So any link between behaviors and gene is going to be mediated through intervening neurobiological pathways, which means that there are coherent things we can say about how is it that genes, for example, confer high vulnerability to schizophrenia or bipolar disorder, and understanding what those mechanisms are has the potential for us to, develop new interventions. Now, it does not mean that the reason a person, let's say, develops bipolar disorder or depression or schizophrenia is because they have abnormal genes. That's a very different thing. That would be a false way of understanding this. It would be a mistake to say that, bipolar disorder is a disorder of abnormal genetics in the same way as Huntington's disease is a disorder of abnormal genetics. That's a different kind of story. But it nonetheless remains the case that there is a genetic component to bipolar disorder, to schizophrenia, to a smaller extent even in depression, and that there are coherent ways in which that genetic contribution is being expressed. And in trying to understand that means that we better understand at the brain level what is happening to a depressed person, and then hopefully the hope is that gives us more tools to understand, more tools to intervene on that and help a person. So again, that I think points to this kind of, this binary tendency that we want to say that either a problem is a problem of biology, and that's why we would take biology seriously, or we want to say that if the problem is not a clear biological problem or a problem biological abnormality, then nothing much is to be gained by understanding the biological dimension of it. Versus mental health problems, mental disorders exist precisely in this middle ground, where mental health problems are not primarily problems of biology gone wrong. Mental health problems are problems of behavior gone wrong, and psychological experiences gone wrong, but they nonetheless have a biological dimension, and they because they have a biological dimension, we can study that, we can intervene on that, often in kind of remarkably effective ways at times.
A couple thoughts jump up, one of which is moving away from the conversation on depression, but I think you drew to some of the nuances that we can also use to think about diagnoses like bipolar, schizophrenia, because I think sometimes we focus a lot of the conversation about the psychosocial contributors to conditions like anxiety and depression. I mean, I feel like the more that I work, the more patients that I see, it feels unignorable that patients who have conditions like schizophrenia have so many different stresses and factors in their lives that either contribute to relapses over their lifetime, but also when you see the story of the initial illness, it feels like you can't ignore the psychosocial aspect. I guess, do you see that coming through more in psychiatry nowadays? Did it used to be thought about more before, and then biology took over for a time? What's your view?
Yeah, I completely agree with you. Psychosocial factors, both, in terms of, in the individual psychological factors, in terms of their personality structure, in terms of their temperament, in terms of their psychological developmental history, in terms of their, the traumatic experience that they have had and their perceptions of those, adverse experiences, as well as the larger societal organization around them, their state of poverty, kind of financial stress, housing instability, access to food, those kind of things. All of them are extremely important. The contributions vary from person to person and case, kind of condition to condition, but they are absolutely vital and essential. And in many cases, the mental health problems and psychopathological problems, they are enmeshed with these psychological and social kind of stressors and issues. So any psychiatry that ignores them or minimizes them or neglects them is going to be a highly impoverished psychiatry and is not going to serve patients very well. What happened in the 90s was that there was this tremendous exuberance around the potential for neuroscience and genetics, and there was this tendency to just conceptualize these problems as these are brain diseases, these are genetic disorders, and there was this strong optimism that just any day now we're going to find the genes, any day now we're going to find the brain circuits, and then we'll be able to fix these problems in a particular kind of way. Now, that that hope did not was not successful, but by early 2000s, it became pretty clear that the biology is much more complicated than that. But it also became clear that some of the most important drivers and contributors of these problems are in fact things that are happening outside the brain. It is these childhood adverse experiences. It is these terrible life circumstances, stressful life events that are happening. And it's in order to improve clinical outcomes both at the individual level and at the population level, we have to tackle those larger psychosocial dynamics. And medicine, I think, has struggled to do that. Psychiatry as well, but also medicine generally. And this is I think is in order to take effective psychosocial action, we need a certain kind of political movement. We need a certain kind of political action, and we need buy-in from social forces and social stakeholders. And the political climate has not been conducive to producing the kind of effective public health changes that people really need. So the emphasis has been more and more on individual-centric interventions. What can we do to improve the functioning of this particular individual while leaving their environment and surroundings as much intact as much as possible. And this kind of basic dynamic shows up in in all areas of medicine, not just in psychiatry. If you look at kind of epidemiological data around metabolic disorders and cardiometabolic disorders, you see this tremendous association with social determinants of health, with poverty, with access to food, with access to quality of food, with access to exercise, and so there's a case to be made that a public health approach is necessary for all health, not just mental health or physical health, but it is certainly much more important in psychiatry than even it is in general medicine. So there's a difference of degree, but not a difference of kind of quality when it comes to these issues in psychiatry versus medicine. I think the trick again is in holding both accepting both truths at the same time. We can acknowledge that yes, there are factors within an individual and there are factors outside an individual, and we have to tackle both. And versus instead, we see this weird polarity in psychiatry where one group just tries to insist that let's just focus on the individual and forget everything that's outside, and the other group says let's just focus on the society and forget what's happening in the person. And the reason this is important is that again, because these things are highly biologically heterogeneous, we have not been very successful in mapping traditional DSM-ICD categories to specific biological processes. But if you look at, what are some of the biggest predictors for the development of these conditions and for their course, these are actually the kind of broader temperamental factors and personality factors like neuroticism. That kind of heavily predict whether a person, for example, is going to have depressive disorder, anxiety disorder, other things now. And oftentimes the contribution of personality factors like neuroticism tends to be greater than the contribution we see from adverse childhood experiences in general. So at the very least, even if you put aside questions of biological mechanisms, we are seeing a very strong interaction between individual factors in the form of their personality structure and life events in the form of both childhood adversity as well as acute stressors later in life. So any kind of binary that tries to split the two, that tries to say either we focus on the individual, either we focus on on the society, is actually going to miss the interaction that drives psychopathology to begin with.
And I think that interaction feels very intuitive, probably to most people, whether you practice in this field or if you know people who have experienced difficulties with their mental health. What do you think is at the root of the fact that nonetheless, I guess we struggle with either biological, empirical evidence for this, or that we struggle to turn it into interventions that work for the majority of people rather than just, 40-50% of people?
I think that the causes are, complex and have a rich history. I think part of it is because our the mental health field is professionally very fragmented. So it's not a pure medical discipline. So for example, cardiologists, when they're dealing with heart problems, and that they are the main specialty devoted to that. Versus for mental health problems, we have people with psychiatric backgrounds. So we have psychiatrists, who are into this. We also have general practitioners and family doctors in all of this. We have people from psychology background. So kind of, people who have a psychology degrees, who might even have PhDs in psychology, involved in this. And then we have, social people with social work background, and especially in the US, most people providing some form of counseling or psychotherapy actually have a social work background rather than a psychology background. So we have multiple kind of different disciplinary backgrounds, all engaged in trying to help people and working with people, and they all bring different assumptions and different background ideas and different preferences and different methodologies, and they're in a sense they're all competing for resources that the system has to offer, and they're competing for prestige that the system has to offer. And if there are asymmetries in how those resources and how that prestige and how the the language that the public gets to hear, how those are distributed, then we set up the scene for conflict between different disciplines, and we set up the scene for kind of competition between disciplines for that, which ultimately ends up hurting patients because they don't get the integrated care we need. So especially I think in the UK with the heavy reliance on NHS funding, there's a kind of zero-sum mindset where you have a fixed pot of money and it can either go here, it can either go here. So people in that effort to try to obtain access to resources, they have to kind of bolster the narrative that they're offering. They have to kind of oversell what these problems are, and they have to exaggerate their side of their perspective, so that they can secure the kind of funding and access to care that people need. So I think that sets up the scene where I think different stakeholders are incentivized to promote one side of the story rather than try to produce an integrated picture that recognizes everything. And I think that the second thing is that at the philosophical level, again, because we're dealing with the mind-body relationship, and it is so easy for people to fall into this mind-body split tendencies, and what colloquially you can call this dualism, and it is so difficult to talk about mind-body in an integrated sense, because the Western world doesn't really have the language to talk about that. We have to tackle this centuries of bias towards dualism as well as reductionism that is very hard to overcome, especially for a layperson. So there are these kind of broader philosophical challenges that we face, and then finally the reliance on these heterogeneous symptom categories, I think, has obscured the underlying complexity. It is so easy to just say, oh, you have generalized anxiety, and here we have medication or CBD for that relying on just that, actually ignores all the messiness, and none of that really gets conveyed to the public, and sometimes not even to the clinicians, and that has held back, kind of appreciating the nuanced nature of these problems too.
Because I guess in conducting, even just thinking to the very basics of conducting research, if you're recruiting people with, recruitment will be people with a diagnosis of major depressive disorder as made by, the clinical psychologist or the psychiatrist who's running the study. But often to the exclusion of other diagnoses, or to the ignorance of the other diagnoses, even though that is not necessarily the reality of that patient's existence in the world. They will likely be experiencing obsessive thoughts that perhaps don't meet criteria for a diagnosis of obsessive compulsive disorder, but they might still be quite bothered by thoughts when they're feeling particularly distressed, particularly on edge, that they've left something turned on, or that something terrible is going to happen, or that if they don't take a certain action, they'll be responsible for all sorts of ills. But yes, so when research is so limited to doing the categories, and like you say, actually in large part that's because of funding, you get funding to research a disorder, it's hard to move forward, I guess.
Yes, yeah, and that's why I think the scientific community has been realizing that too, and that's why there has been this big push towards transdiagnostic dimensional research, because people have realized that just having this methodology where you take one DSM-ICD category and compare that to healthy controls, that's actually not the ideal kind of study design, because heterogeneity and non-specificity of the mechanisms, both at psychological and biological level, and that it makes much more sense to study these conditions at different levels of specificity, looking at larger clusters of these problems, like what it is that internalizing disorders all share with each other, and in some cases drilling down on specific symptoms, and why is it that, for example, anhedonia, what mechanisms might be involved in anhedonia versus psychomotor retardation versus just talking about a depression level syndrome. So looking at these things in a transdiagnostic manner, and also at a kind of multi-dimensional manner, is very important if you want to make progress. And right now it is the case that our treatments have generally limited efficacy. This stands for both medical treatments and psychological treatments. Our psychotherapies and our medications are not as effective as we would like them to be. It would be great if we had more effective treatments, but we're not there yet. And it's important to be transparent with patients about that the tools we have right now are limited and somewhat imperfect, and they come with fair degree of risks and problems too, and that they're not going to be a magic fix. They're going to, for a lot of people, they can make the symptoms more tolerable and bearable enough that, there's an improvement in functioning, and a smaller subset of people experience more dramatic improvements. But for a lot of people, the symptoms are not going to go away. They might get reduced to more kind of bearable functional levels, and that we should not overpromise, or we should not present a hyped up version of what our current tools can accomplish. And I think the problem has been that we have not been sufficiently humble as a profession. The narrative that we have told the public is quite disconnected from the scientific and medical reality of what we can actually accomplish.
Yeah, and I think it's refreshing, and I think luckily perhaps starting to become increasingly common to discuss this level of nuance in terms of the limitations of our treatments. And I think it's, again, an area where binaries often arise in saying that if the treatments aren't helpful, then they aren't helpful at all, or no, how dare you say that the treatments aren't helpful, they're extremely helpful, they're only ever helpful, there aren't any problems with them. I mean, can we think about some of the issues that there are with treatments, both if we think in the group of depression, anxiety type conditions, but also conditions where people might experience disorders of thought, psychosis. What are some of the problems that you find, and how do you manage them when working with patients?
Yeah, I think so. It varies quite a quite a bit, especially with regards to the problems that people tend to experience in the short term or in the acute term. When perhaps the medication is new or when it is being started, versus when they have been on medications for some time, and they're in a more maintenance stage of treatment, and so the nature of problems kind of often differs based on that. In the short term, we tend to see a variety of what you can call paradoxical reactions, where, let's say, you have someone with depression and anxiety, and you start them on an antidepressant, and they'll suddenly have a flare up. Their anxiety will get worse. Soon after starting an antidepressant, they might experience states of agitation. They might experience states of irritability. They'll have this intense dysphoria that can sometimes even turn into suicidality at that times. So we have to be mindful of those, that sometimes we start a medication, and instead of things immediately starting getting better, we get a paradoxical response where things suddenly get worse. So we have to be any kind of when we're starting a new medication or we're increasing the dose, we have to be mindful for those possibilities. Then we have to discuss them with patients that something like this happened, be on the lookout for that. And then there are various kinds of physical side effects, that pose tolerability challenges. With SSRIs, for example, you get a lot of gastrointestinal side effects. People can have sexual dysfunction issues, with kind of ongoing use, that can become distressing. People can have things like headaches, other things, and so there are various kinds of tolerability issues that we need to be mindful of. When we start entering into the kind of long-term maintenance therapy, then the metabolic effects start becoming problems. So weight gain over time, increased risk of diabetes, increased risk of hyperlipidemia. And that often poses, a challenge, that if a person has responded very well to a particular medication, but now 6 months later they have gained a lot of weight and their kind of HbA1c is creeping up, we can't just leave it like that and increase their risk of cardiometabolic problems. So the considerations change. So we have to do that with antipsychotic medications. As you're well aware, the risk of motor movement disorders becomes prominent, as we increase duration of treatment. And then something that has been generally neglected historically has been the risk of antidepressant withdrawal, and discontinuation issues, and not just with antidepressants, but with other forms of psychotropics as well, because people stay on these medications for years. When they do decide to come off them, historically they were being taken off very fast, and then they would have severe withdrawal related effects. And because we didn't have enough research investigating that, there was a general skepticism in the medical community about whether these things even cause that severe or protracted kind of withdrawal. So it took a lot of effort by kind of service users and other kind of patient communities who had been through really negative experiences, and they raised enough of a hue and cry that the medical community began to pay attention and began to recognize this as a serious problem. So I think with all kind of psychotropic use long term, withdrawal issues become pretty significant, and we have to be mindful of them.
Why do you think there was such a reluctance for professionals to hear the concerns of patients when it came to the issue of medication withdrawal symptoms?
I think it's a combination of different factors. One was that we did not have good research data on this phenomena. There wasn't any major funding agency that was interested in exploring, what happens with long-term medication use, what kind of problems emerges. So there was a big gap. For example, in the U.S., National Institute of Mental Health is the biggest public funder of research, and in the last 3 decades, they have been much more interested in doing basic science research or doing or developing innovative medical treatments, and they have left clinical trials largely to pharmaceutical companies. Pharmaceutical companies obviously are more interested in developing a medication and studying its acute efficacy. They're not interested in studying long-term side effects. So there was we had this problem of its incentive that no major research funder was really that interested in the question. Ideally, National Institute of Mental Health should have been, but they set their priorities kind of differently, and in similar kind of ways, I'm sure that in among European funding agencies, no one had really made this a priority. So because there was no research money going in that direction, it was never studied. So there was no general knowledge base to link to, and because these problems, the severe versions of them were sufficiently uncommon that the average clinician was not seeing them. So a person could treat hundreds of cases of depression and not come across a very severe case of withdrawal. And the milder cases, when they would come across milder cases of withdrawal, they might just attribute that to, oh, this is the person's depression returning, or this person's anxiety returning, or it has just they had a change in quality. So there was a kind of an inherent bias towards interpreting these withdrawal related symptoms as in relapse terms rather than withdrawal terms. So when people did kind of start raising this concern more forcefully, the physicians would look to their own experience and would say, I've been treating these patients, I myself am not seeing this, and then they would look to the literature and they would say, there are no studies on this. So they would start from a place of skepticism, given that, and the tendency would be to, there's something unusual going on here, but it's probably not the meds. Versus the situation would have been quite different if we had paid attention to long-term effects from the very beginning, and if we had good scientific data from the very beginning, then people would have started from an informed place.
Should there be a responsibility for pharmaceutical companies to study more than the acute effects of their drugs?
I think so. I would personally say so, but but forcing them to do it, it's in places like the US and also Europe too, would require legislative action, and pharmaceutical companies have far stronger lobbying than most physicians, and so the general tendency is that pharmaceutical companies tend to only do what they're strictly obligated to do. But so for example, FDA requires you need two large placebo control trials, so they're compelled to do it. For example, if it was mandated that you have to do long-term safety study too, things, and there are certain minimal requirements. There are certain minimal post-marketing requirements even now in the U.S., but they were not strong enough to pick up these kinds of issues. So there's certainly, I think, a responsibility on the pharmaceutical company side, and we should look into getting them to do it. But I think at this point, what I think we really need is public funding agencies to make iatrogenic harm a priority. They need to recognize that this is getting to a point where this is a crisis in many different ways. It's a crisis of clinical care, but it is also kind of a crisis of public relations too, around psychiatry, medicine, etc. And there's genuine suffering. So many people are dealing with this problem and feel abandoned by the medical community. So this needs to be a funding priority in my view, and by made a priority by medical research organizations.
With the public relations crisis in mind, and again, I think I'm thinking about topics that we've discussed on the podcast before, and we aren't focusing on today, but things like the debunking of the serotonin hypothesis of depression and other issues like that. my question is, how do you bear these iatrogenic harms in mind in your clinical practice? How do you use these medications? And again, we're not focusing on other types of treatments, but specifically, what is your approach and in your practice, but perhaps also more broadly to this public relations crisis?
My approach has generally been to talk about patients kind of in an open and transparent manner about the nature of these problems as well as the nature of these treatments. So I try to convey to them that the reason, for example, they're depressed or anxious is because of a confluence of different factors coming together. Again, the contribution varies from person to person, so my formulation of what is going on in any particular case is going to be different. But I emphasize what are the different factors that we can identify that are leading a person to be in a depressed state or an anxious state, and how this does not just involve biology, but there are these kind of psychological factors involved, there are these life factor involved, there are these developmental factors involved, and I myself do not use the language of chemical imbalances or brain disorders because I find that to be very misleading and deceptive. So, and once in a while, a patient might themselves bring up the language of chemical imbalance, and in that case I kind of correct them. This is actually it's not literally true. Sometimes people use it as a metaphor, but it doesn't represent the nature of the problem very, very well. And so we talk about that. And then with regards to medication, I convey that they are not fixing an abnormality in your brain, but rather we're using them to control symptoms and make these conditions more bearable for you and to improve your functioning or shift your emotional processing in a prominent in a positive direction, or we're using it to control your body's state of arousal, etc. Whatever the specifics of of the medication condition might be. But they're not going to be the magic fix. They to the extent that your mental health problems are enmeshed with your life circumstances, with your psychological patterns, the medication would not change that, and those things require to be addressed through other means, either through psychotherapy, through lifestyle interventions, through other forms of help. And I think if we take the time to have these honest, transparent conversations with the patients, then they would not leave with these mistaken ideas about chemical imbalance or medications fixing a chemical imbalance, or them having some kind of a biological disease in the same sense as diabetes, a biological dysfunction. So that's what I've been doing, and emphasizing the a more sophisticated conceptualization of problems as well as treatment. And again, I emphasize medications are imperfect tools. They help, but they also have the capacity to harm. And the balance is dynamic. If the medication is helping you right now and you're not having a lot of problems with that, that's wonderful. But it does not mean that 3 years later, the balance will not shift. And if the balance ever starts shifting, that the medication is causing more problems than it is helping with, then we need to take action and, either change treatments or figure out other non-medication strategies. And so I think patients being aware of the fact that benefit risk is a dynamic thing over time is very important too.
Dr. Aftab, thank you so much for that tour de force around these varied and complex topics. I'm really sad that we are running out of time, as I think I could probably carry on quizzing you for hours. I'm just wondering if there is anything that you would want to point people to in terms of your work, any other sort of important facets you'd like to highlight that I haven't brought out as yet today.
I think over the past 2.5 years or so, I've been working on a Substack newsletter called Psychiatry at the Margins. So that's kind of a useful public-facing resource that I've been working on that goes into some detail around these conceptual and scientific debates in the field. So I'll refer people to that. There's also a recent book from Oxford University Press called Conversations in Critical Psychiatry. That is an edited collection of interviews that examines these issues in more detail too. And I think those would be useful resources for people that are interested in exploring these questions.
Amazing. We'll definitely make sure to link to those in the show notes, as I've really enjoyed reading your work there as well myself. Thank you so much for your time. It's been a pleasure seeing you today and speaking to you.
And thank you for having me. I enjoyed this.
Thank you.